Hello, everyone. Today, we're going to kind of do a little bit of a journal club style discussion of an article that Matt shared with us, which we thought it was a very interesting one. So I thought it'd be a good idea to talk about. This article is by Seth Peterson, Mark Shepard, Joe Farrell, and Daniel Ron. The article titled "The Blind Man, the Elephant, and the Continuing Education Course: Why Higher Standards Are Needed in Physical Therapist Professional Development." And I think this is a excellent topic to talk about because with a current state of physical therapy profession, I think there's it's kind of weird because we have transitioned late in this last decade or so towards more evidence-based practice, and just the way our history of our profession has gone, we've kind of in a transition period where a lot of people are still follow clinical practice guidelines that aren't evidence supported and believe that there's truly one way of treating patients, in a sense there's a many way of approaching, but there's no right or wrong answers to anything. Kind of weird, and I'm sure you guys will have more to say about it, but that's the one that we're going to talk about. I really like this question, which I think would be a good way to go into this discussion, where it says, have you ever gone to two different doctors or therapists and have gotten a completely different advice for the same problem? How did that make you feel? And I think that that would be that's a very good question to lead into this discussion. Do we want to start what you guys took away from the paper, or
Yeah, I mean, this article, I know it came out a couple years ago. I think like 2022. I'm one of those guys that like I see something and I stash it and I save it and I'll get to it and I never do. But I got the intrusive thought of bringing it up for our like conversation today last night, and I shared it with Sub, and Sub read it. It was actually a very easy read, which is nice. But yeah, I don't know. I think we're all kind of like-minded in the fact that we're like passionate about adhering to evidence, I guess would be a good way to put it, and like no BS, no nonsense. And I think there's just I get so frustrated and I get probably too much because I'm kind of a nerd about this stuff, but I get so mad when I see people like, yeah, and the variation in practice is okay, I guess, but like to an extent, right? If someone's coming in for shoulder pain and then, some guys starting checking out like their rib cage position, their pelvis, their foot, right? I'm sure some people out there would blame it on pronation, right? Like foot pronation, right? So this stuff, it gets out of control, I feel like. And I like the fact that I really liked the figure that they had, right? You got somebody blaming it on the fascia, right? We know that we got that camp, right? You got the fascia camp, right? Motor control. Some people are big motor control people, right? You got that camp. I mean, I think the motor control is a classification in for like low back pain, right?
low back pain
So
class B? Yes. Here, let me share the picture of what we were talking about, what you're talking about, so that we at least have an idea.
yes, right. That's the picture I was referencing. Then you got somebody, blaming it on the pelvis. It's an upslip. Like I said, pronation. And then you got my guy, which I probably resonate the most, being a pain neuroscience guy a little bit. Right, we're all biased. It's in his brain. Which I thought's funny. He's just sitting back chilling. You fools. But right, and it just goes to show there's so many different schools of thought. And I do like how this article brought that to our attention. And I certainly don't have a solution, but I think identifying the problem is a good place to start.
It was a good article, and it is interesting to put into perspective how many different treatment methods there are. And no matter where you work, no matter how aligned you might be in your values, like everybody's going to have some different differentiation. Somebody's going to have a different approach or thought, and I mean that's the point of the therapeutic relationship, I guess, is to there's a certain degree of creativity and just like getting to know your patient and the patient getting to know you. I thought this was an appropriate article, definitely, because like mentorship is something I'm interested in, and continuing education offers a degree of that. But obviously, like, yeah, we want to kind of limit the variability um, in our practice and kind of working on identifying like best evidence practice. When I'm working at my clinic, we see our patients, and our patients will see me and one other clinician. And I think that's such a kind of valuable and unique thing that not every company has, and there's pros and cons. But I think that for a patient gets to see different perspectives and to hear different perspectives, and then as a clinician, um, we can kind of work on helping each other a little bit more, because got to communicate and kind of share constructively those things that we agree with or disagree with, or can learn from one another, even if it's maybe something I don't completely align with. Being open to new ideas.
Let me give a quick synopsis of this article so that like I can kind of follow through with it a little bit more. Pretty much this article mentions that like in our physical therapy world, we have so many methods, mostly outdated methods of focusing more specifically in continuing education, kind of like saying like a blind leading the blind, when the guy or the person that is teaching is using an outdated evidence, right? Or doesn't really know why, but is teaching someone new physical therapist to do certain things, and now they're just kind of following it mindlessly without really questioning why. Pretty much that's where this article targets, and those couple of suggestions that this article is offering is pretty much saying like do something about the continuing education courses that is available within a professions right now, which is continuing education is essentially like for clinicians that have graduated to keep up with their skills, so that it's a minimal requirement for us to keep our license, and also kind of help us make sure that we are keeping up with the current guidelines, essentially, right, as to how physical therapy works and stuff like that. So they're saying that the minimal requirement is essentially minimal. It's just there's not a whole lot to that, right? And they're saying that maybe even check on the continuing educations that is offered, because one of the things that this paper found was that saying that 50% of the courses that are available weren't evidently rooted, or they didn't really follow clinical guidance. And second is saying that like maybe making mentorship a more priority, because we know that mentorship is huge. I think Anthony and Matt, you can talk about more because you guys did like the mentorship programs with Clinical Athlete, right? Because they're a very good mentorship program available for a
Shout
lot of new
out.
clinicians. Yes, sir. Um, and which one of the things that the other things that they suggested was saying that like maybe making a fellowship programs or like residency a mandatory thing, which I think it's kind of a reach, and I think I have a little bit more to touch on that because I think that's in itself is a problem, just based on our professions. But that is the synopsis of it, and I want to go back to that questions like we can have different opinions as to how we can approach treatment. But if it's not helping the patients or offering things that could possibly be harmful to them in the long run, what good is that? Like opinions, or what good is that different approaches that of a value to the patient? You know what I'm saying? And so I think that's where a lot of it is where the issue stems. Like, I don't know, do you guys want to add more onto that of that question of like, if two different people or therapists or doctors are offering? Because like I feel like I'm sure you guys have come across, saying, oh, I got a physical therapy with this person before and said this one, or like my chiropractor said this, my doctor said it was this. Like, what do you do to that situation?
Yeah, like I said, it is for me something that does frustrate me a lot. Is just having like the massive variance. I guess I have two thoughts. I think I heard it somewhere. Like, right. So the chiros can get a bad rap, right? Chiros can get a bad rap out there, right? And I think it was a chiro who had said this maybe on social media. I've seen it. And it says evidence-based rehabilitation should look pretty similar, whether it's a chiro or a PT giving it. I was like, yeah, that's cool. I like that. Right. So that's one end of the spectrum, which I'm more on. And then I guess the other end is, yeah, I mean, pain's super complex. Each individual is super complex. So like, there's gonna have to be some different thoughts that go into it. I don't know. Again, I think we as clinicians, like, we don't necessarily want to like overcomplicate something by, again, like that example I brought in earlier, right? With a shoulder pain. Do we always need to go to another part of the body? If someone says, yeah, my shoulder hurts when I do this, like, do we need to like blame it on their thoracic rotation? Some people would say yes. I don't know if I agree with that. And again, it probably depends, right? If you're working with like a rotational on a sport athlete, sure, that's a consideration. But yeah, so it's just, you don't want to overcomplicate things, and then you also don't want to oversimplify things, right? You got people who, they'll blame low back pain on the psoas muscle, right? One muscle. How can one muscle play such a massive role in something like back pain? Those are my thoughts. I
What
don't know.
about you?
I thought I sometimes have is like people will oversimplify someone's pain, meaning, right? Let's say this person has low back pain. We didn't dig into anything subjectively, but we do an assessment and we somehow find that their psoas is tight, and we blame it on that, right? So that's like oversimplification. And then I often find that people will like overcomplicate the rehab, right? They're having them do all these like fancy corrective exercises to correct that, right? So in my opinion, that's a little bit of an oversimplification of what their pain was, and then an overcomplication perhaps of the rehab.
Anthony, do you have anything to add? Because I feel like oversimplifications versus overcomplications is like a great point to bring up because I feel like this goes very well to
Yeah.
this discussion.
Oversimplification, overcomplicating. Those were what you're saying, those 2 points?
No, I'm saying like, do
Um,
you have like any like something to think about? I guess of like having different therapists giving a different opinions on the same low back pain, for example. I guess like how do you
sure.
feel about that?
Uh, yeah, it's definitely really common. And my head goes with that is like, bring it back a little bit, is how we have residency trained therapists who versus a non-residency trained therapist. I think like the command or like their ability, like a residency is their ability to think in systems, and like we all are able to think in systems of like um, we're going to think biopsychosocial, and like how do we communicate with our patient, be like with them to be able to see like what's going on in their lives, versus biomedical to think about like what are we getting from ortho. Um, so that's like 2 PTs, but when I'm thinking about it, I'm thinking like you got like the communicating with, I don't know, communicating with ortho and translating it into something that to the patient's language.
I feel like what you guys are saying is like there's a lot to unpack there, but I think the biggest issue, well, I guess I don't want to say issues, but I think the biggest thing should be why does it matter to the public, right? Because to them, even though they don't know, right, they don't really know as much about what happens behind the scene, and they're mostly there because they got issues going on, and so I think to me, educating the public about our
Mm.
profession, right, and advocating for our profession is huge. And so, like telling them this is what it is, right. But at the same time, I kind of want to go back to this simplifications versus overcomplications, like what Matt was saying a little bit. Um, eh, is because like I think we almost our profession almost kind of goes into this well, most of the time, one way, overcomplicating things, where they're like how you're saying they're correcting about postures or things that's leading into an issue, right? And essentially using this like I guess fear eliciting narratives to make them feel like they're doing something wrong, right?
I feel like
Uh,
sometimes, and I don't mean to interject, but like I feel like
yeah.
sometimes like with ortho, we're given our script from ortho with a diagnosis, and we have to, how do you break it down to a patient in a way that isn't like gonna bring up fear and all those things? Because like once we are handed the script, it's our like being our job to present it to the patient in a way that's like, okay, this is has multiple meanings, and maybe this is different ways we can look at it.
I very rarely reference the script, but yeah, I guess if I
Yeah.
if it does, sometimes if the patient asks, I'll bring it up. But yeah, I very rarely reference.
No, I agree with you. I think no, that's a good point because like when they come to us, they're already like, oh my God, like they're in a very like hyper state. Right? They're just thinking that there's something's wrong with them, right? And like how you meant Anthony, you're mentioning is like our job is to kind of bring them down to say, hey, this is what's actually going on, right? But when they get to us, and our job is to pretty much ensure or make sure, like ensure that they feel like they understand and they're more informed about what is going on. We tend to overcomplicate things, like saying like like we do range of motion check, right? And you're looking at, oh my goodness, look at the one place is tight, right? Your hip flexors is tight over here versus like your quads tight over here, right? And they're like, oh my God, I need to stretch, whatever, right? Or like I need to strengthen, right? And then they're like, oh no, look at this. There's your hip drop on the one side, your pelvis is rotated anteriorly. This is why you're having problems, right? And so we tend to overcomplicate things, overcorrect it, and then now you just catastrophize their entire nervous system even more with the negative narratives to reinforce that fear avoiding behaviors. You know what I'm saying? And I feel like our profession is notorious for that. I don't know if you guys would agree with me or not.
Yes, obviously. I think we're all here very passionate about narratives, right? We are narrative people. And yes, that's part of my problem too, right? Like again, let's go back to the oversimplification. I find they often, right? Like the classic one here is your core is weak. You have a weak core, bro, right? Like that's kind of a classic one you always hear, right? And then, or oh my God, dude, like your glutes are weak or your glutes like aren't active.
Think math internet's not the greatest tonight.
Those poor glutes, they're not activating.
The glutes are not activating right now.
The internet, the interweb has let us down here. So we gotta use the droid right now.
All right, bro. Like,
Yeah,
let's pick it.
There you go. They're the boys. The boys. Oh my
Let's
God.
pick it back up.
All right. Excuse me while my phone rings. Hold on. All right. What was I saying? I was talking about narratives and how narratives are important, right? You got these people who, whatever, they're told they need to activate their glutes, they're told they need to activate their core, they're told they can't bend their spine, right? These are all harmful beliefs that can come from some of these different schools of thought, right? All these different camps. And then we might have somebody who holds they've been to 3 different PTs and they have all these different beliefs about themselves, right? And that's not good, right? And I think a good common ground that we can agree on is let's try to foster a mindset or belief of resilience, right? If we're all agreeing on one thing, let's agree on that. Whatever, you can do your own thing, you can treat it a little differently, but how about we agree on that and not point out to these really minute things, right? That make people believe these harmful narratives that aren't useful for them. And yeah,
I think that's where clinical guidelines is so important. Is to at least it's a guidelines for a reason. You don't necessarily have to do exactly that. Sometimes patient preference makes a big difference on your treatment approach, right? So you can use evidence-driven guidelines that's given it to you, right? And then take the patient preference and use that to come up with a treatment or a way to approach certain things, right?
right.
But I was asking Anthony earlier this question where I was saying that when I see patients, right, I look at their physical abilities, and if I see them, they can do certain things, and I say, oh sweet man, you're good, right? You're good. You can do all this stuff rather than focusing on what they cannot do, right? No special tests, nothing, right? And I just kind of look at it, and I sometimes question this. That do you think that's an oversimplification of what physical therapy profession is? We're kind of downplaying everything, right?
I mean, that's a fair counterpoint, but that's generally a message that I vibe with. Yeah, yeah, and I think some of it is marketing related. You'll find, at least I found in the cash-based space, the need to find a problem and diagnose it is really emphasized because yeah, I mean, if you come in and you're yeah, dude, you're good, bro, you're a stud, you don't need PT. Obviously that's not going to sell, and obviously I'm being sarcastic, but Yeah, so that there's more pressure to kind of really dig into find the problem. But no, there's obviously a way you can do that. Reassure a patient is a good word to use, right? Like, hey, yeah, I found these things, but overall, I think you do this well, right? You can throw in a positive comment as well.
I think Anthony, we're talking about biomedical versus like from like an orthopedic or a medical doctor. Like they're trained to see the problem. And I don't know if you want to touch on that a little bit more.
I mean, that was like what you're saying, that like ortho or the medical doctor is going to find the problem, and like our job is to kind of put it into perspective of like the whole system. And like if we know that the body's resilient and that there's a good natural history, if we're promoting movement and general well-being and like creating a good environment for the patient, like as a PT, like using like, I don't know, incorporating the bigger picture, like it's better for the patient. There's like you guys were saying. So sometimes we do need to
Um,
downplay,
sometimes you do.
and
Yeah, it's
not
not.
to the degree that we're ignoring anything. Like obviously we went to PT school so that we can identify like anything that's going to put the patient at risk of like injury or like harm. But like if we can create an environment, or like if it's more beneficial for the patient to not worry about certain things like that, that's a part of our job.
Yeah. You don't want to downplay it so much that like like we're saying like, oh yeah, dude, you're okay. But you also, I feel like you definitely don't want to overcomplicate things and essentially make them believe that there's something's wrong with them and that they're gonna break down with this a single step. Right? And
The
I used
certainty
to.
that some people, the certainty that some, sorry to cut you off, man. That was
No,
bad.
you're good.
We'll have to edit that out. The thing with me is just the certainty that some people say, like, oh my gosh, it's your whatever, your insert body part to blame, right? That's always been baffling to me. Like the certainty that some people will have. It's like, how do you have the audacity to say that?
Oh man. I used to hate that it depends answers, like, in school. But it really truly depends. But at the same time, are you saying like that like you can't be certain that this is the reason.
The
You
BS
know?
meter, right? The BS meter,
Yeah.
right? Yeah, anybody who speaks in absolutes, that BS meter is.
Yeah. I would agree with you, man. So how can we educate? I feel like educating the public, educating the general public is probably the biggest thing we can do, right? To make sure they know what physical therapy is, what they entail, but at the same time, educating. I hope that the medical profession does a better job educating like the patients that when they say degenerative disc disease, it doesn't mean they got disease. You know what I'm saying? It just means they are old. They just age related change. You know.
Nah, you don't have
Uh,
degenerative disc disease. You're just old.
Right. I mean, I feel like we need to do a better job educating, and we can only educate better if we make sure that we know what we're talking about. We keep up with that with the evidence. We read the papers, right? The new paper that comes out, like we're doing now. Um, I I'm like a little bit dumbfounded by the when this paper was coming out. Like when I was reading this paper, it was saying only about 50% of the continuing education that is in available for us, and then to maintain our license are the one that follows like current guidelines, and which I was like, that can't be true, man, because Medbridge, Chad Cook out there, he's killing it. You know what I'm saying? Like, so I looked at their reference and looked at it. I'm like, no way. They had um so they looked at this paper uh they looked at 2,406 available courses, right? They pulled that out, which, I think in a grand scheme of things, that's not a whole lot, but at the same time, that's a big sample size. And only about, oh no, 52%, which is about 169 total. No, wait, what's it? Most courses, about like 57.7%, taught interventions not supported by current practice guidelines or systematic reviews of those things that they found. And I'm like, what? That can't be true, man. Like only one third of are like one third of, which is 34%, are taught interventions that were supported by the clinical practice guidelines. Um, yeah, like, it's kind of crazy to me, right? Especially as a I know, Anthony, that you, Matt, like you guys really found like clinical athletes, right? And which really helped a little bit better, which I think kind of we can go and talk about mentorship, which this paper also talks about being mentorship being like a huge part of growth in our practice. But man, it is kind of crazy to me that like this is still a thing.
I don't know. I'm a believer in finding people who are smarter than you, and that's something I has done since when I was a student. And yeah, you know what? Is it tribal and am I biased? And sure, right? You could definitely accuse me of that, and I would be guilty. But I don't know. I do believe strongly in this community, and I believe that they're about things that I'm about, which is right, sticking to evidence and not doing nonsense and BS. And I think those are good qualities to look for. But yeah, obviously, I'm thankful to have found them. And yeah, as far as people out there, I'd say, find things that you're passionate about. Obviously, again, you're going to be inclined to hang out to do things with people that agree with you, right? Generally, that's just the way we are. That's the way we're wired as human. But yeah, right. But maybe be a little skeptical at times to your beliefs and challenge your own beliefs. If you feel like you're sticking too hard to one thing, right?
How do you feel about this? So the other thing that this paper pointed out, Anthony, did you want to say something?
You gonna take a manual course, Matt?
Not unless I'm forced to.
That's
Okay.
a good one.
It would probably make me a better clinician, a more well-rounded clinician. But I can't say my internal drive to do that is very high right now.
Well, yeah.
Is that nuanced enough for you?
Yeah.
Oh, I'm gonna I'm gonna follow up with what you're saying, Matt. Like, how do you feel about like uh, clinicians not following the recommended guidelines, right? And so another
Yeah.
systematic reviews, yeah, and another systematic
Well, the one thing
reviews
I will
that
say, the CPGs, I don't know if can be taken as gospel, right? I remember there was a low
no, it's
back
not.
CPG that,
Yeah,
right. That's the one thing I just want to touch on, right? There was a low back one that came out a few years ago, and people were really fired up. I didn't read into it. I don't remember what the passion was about.
it was because of they were saying that you can use manual, right, soft tissue massage and things like that as a means to treat low back pain essentially, and that's why people like. I think this was like more like uh chronic, not acute, but chronic low back pain. They can say use that. I don't know. Maybe it was acute. I don't know. It was one of those things, and people were like, "That's dumb." But I can see the
Adam
value in
Meekins
the
was
manual.
fired up for sure. I remember
Yeah,
listening to him, and I was like, oh,
yeah. When I say a recommended treatment that is evidence driven, I'm saying like what I mean by that is like keeping up with the articles, right? Looking at meta analysis, looking at systematic reviews, and looking at this large group of studies. What do they say? Like how? And I know human beings are like complicated and different ways works for different things, right? But if you have enough large sample size, you could somewhat draw conclusions from it, saying that like maybe I should use this, and that's what I mean by like. And we know that clinical practice guidelines are not always like everything. It's not a gospel, right? But I wanted to say like is like how would you feel like in it saying like in this systematic reviews by Joshua Jadaro, uh, where it says, "Do physical therapists follow evidence-based guidelines when managing MSK conditions?" Right? It's saying that like they used 94 different studies, and only about 54% of those studies that they found, which are 23 studies, that they actually follow what is recommended, and others don't. They're still using, things that aren't recommended, or like where they're just kind of making things up as they're going, right? Like, how does that make you feel in this profession?
Yeah, I mean, like frustrated, the word I've used several times for sure. Um, but yeah, I mean, there's not necessarily anyone stopping those people or whatever. I'm blanking on the term, but like guidelines or guide rails that have to keep these people in check, I guess, right? They can, right? You have autonomy as a clinician. And that's good in some ways, but also in other cases, not so good, I guess.
There's hope for the profession. I mean, like in places that like don't abide by like the guidelines perfectly. I mean, all it takes is one clinician to do like, I mean, to keep trying to keep working on like doing just like one small thing, like it can have an effect. And like I said, like in our clinic, we're constantly learning from each other, and like whether or not everything we learn from each other is evidence-based practice, by like digging into this or having conversations about what ways we can treat better, um, based on research, um, what's current. Like, yeah, we can
No,
definitely we can get there.
I think well, I think what you're trying to get at is like more so like in the mentorship more so than anything, right? So I feel like we find much more value in mentorship than like between or just kind of helping each other uh, educate each other on how to approach different things, understanding that. But my problem is like the way I see it is like here is like saying like, okay, well, you graduate and you should use continuing education course to like, help yourself to get better. But then we're learning that continuing education course actually don't really follow any sort of like evidence-based guidelines or evidence-informed guidelines, right? And then we're saying finding that like even if they are available, the therapists are not following it, right? And you see how that the problem kind of ends up becoming, and which is why I think that I really truly do value mentorship. I think mentorship is awesome, right? And I think there's far more beneficial to that to make you a better clinician so that you can educate the public better. You know what I'm saying? Um, I think that's where my heads are going at. This other thing that the paper did brought up was the questions of like mandatory residency training, right? How do you guys feel about that? I have a thought on that.
I mean, I don't know. Like, I think if they were to make it mandatory, they would probably change like the cost of it. I mean, I don't know. I don't think it would be a bad thing, but also people don't like being told what to do. It would be very different, right?
Yeah.
And I believe, right, all MDs have to do residency to practice, right?
Yes.
Right. So it would be more, I don't know. We are doctor professions, right? So maybe it's coming. I don't know. That would be interesting. I'm not opposed to it, but I want to hear you can share your thoughts too.
Anthony, what about you first, and then I'll.
Um, I mean, we've come from being a master's profession to a doctorate profession to being then a residency profession. Like, it's a jump, and I don't think it's necessary. Like, I think you learn enough getting into the profession to. I mean, we need therapists who are generalists. We don't need everybody to go into residency be like, yeah, I don't know. I think there was a few more arguments that I think that we don't necessarily need to do that.
Like, would you say like the person that is trained, at least in this current environment, would you say that they are better than the physical therapist like you and I, who doesn't have residencies? We haven't gone through it, and we don't have the OCS or SCS, whatever CS we there is.
I think it's like, I mean, I don't know. Sometimes we need like the idea of like we have leaders in the profession, and sometimes we need followers. And like school of thoughts, we're part of one school of thought, and we're distributing like our knowledge of what we're learning from all these other people. We could do residency, but like, do you need to do it right after college? I don't think so.
Yeah. My thoughts is like well, first of all, I think I should mention this. Like, I remember when Matt was saying, like, when we were getting our first job, and I had a very cushy job where I was barely seeing anyone, you know. And now, you were mentioning about like how, man, as a new grad, we should be getting reps right now because that's how we learn, right? And I feel like getting out there and doing the things that we need to do to learn is far more beneficial. And if the residency is, kind of geared towards that, right? Then hell yeah, man. Like I think it'd be extremely beneficial. And if it's guiding us to use critical thinking to do different things, different ways of approaching what is going on and trying to differentially diagnose or whatever, right? But at the same time, man, one, it's not that complicated. You know what I'm saying? Like we don't need to overcomplicate things. Is how you were saying, right? We just need to kind of meet where they are and use. Like, we don't need to tell them that they got, like, this wrong to get them to buy in, is what I'm where my head's at. But my second thought is, like, over here is, like, almost it's almost like, one, physical therapy school is already expensive. Debt to income ratio sucks, right? We
Indeed.
barely get paid, right? We barely get paid, and it's extremely expensive school.
Hear us out, APTA. Increase the pay.
Exactly. Right. And so when we go into residency, we know that it's common that like you take sometimes, you take pay cuts, right? To do that. Or you have to pay out of pocket. You know what I'm saying?
Right.
It's common. Some programs, like some of the jobs like do offer that, and they will pay for it and they won't take a pay cut. Right. But it's not uncommon for them to take pay cut to get to do the residencies. When after you finished it, right? After you finished your residency, you don't even get paid increase.
Mhm.
It's crazy.
So what was the point in the first place? One, I don't know if you were saying earlier, Anthony, that like the difference between someone that has a residency versus non, right? The care that they provide, it's not that big of a difference, right? So there's already that, and on top of that, you're taking a pay cut. There's you are paying for it, and you're not getting paid more after you're done with it. So what is the point of residency? You know what I'm saying?
I mean, you could kind of make it the same question of like, what's the point of like grad school? I mean, like, I feel like to agree, it may not immediately increase your pay, but there's definitely increased potential to learn or have an impact in your profession as residency.
Yeah, right. Like an investment in yourself, getting better.
Yeah.
Yeah, but if
making connections, I guess.
I hear you, man. Right? I hear you, but I think you kind of almost have to take into account, to at least this is what I think. If there's no return on it outside of maybe a little bit better at doing clinical treatments, and I think I gotta double check this first before I say anything, and don't quote me on this, but like what would be the difference between a person that went through residencies first and someone that has been treating, right? like how much of it are they just accelerating what they're learning, or you know what I'm saying? Like, the
Mhm.
guy that's been treating for 5, 6 years, what are they? Who do you think is more? And on top of that, reimbursement rate too. That's another thing. Someone that has a residencies bills for a unit or whatever, they're getting reimbursement at the same rate as you and I will bill for it,
Yeah.
right?
Exactly. There's no incentive for PTs to be like, right, good. It's more about
Uh-huh.
being productive, right? And that's a problem. And that's probably, this article didn't touch on that, and they may. I'm surprised they, or yeah, maybe they should have. But
They
to me,
they
I see
didn't
that
touch on it, but
there's no incentive for us to be quote unquote good, right? It's just to, do you see more people? How many people do you see this week, Matt? Okay, cool.
yeah,
Yeah, you hit the bonus or not? Like it's a numbers game, and it's
yeah,
the
and
unfortunate
I think
circumstance we're in.
yeah, I think that's a big issues within the healthcare, and not just for us, but also for you know any other professions out there. You know what I'm saying? Like healthcare profession. So that's where I'm at, man. That's where I'm at. I don't know if you guys have anything else to add on to this, but I think that's what I wanted to kind of touch on.
Yeah, no, I like that.
Me too. I'm looking for a charger. My computer's dying.
Yeah. Um. How about a reflection uh question for you guys? Like, what would you if you could change one thing, right, to help our profession better and to help patient better? What would you do? And this could be our closing question.
I would say, so having mentorship from a qualified clinician. Now, what would go into that definition of qualification is probably a long conversation that I don't know we need to have, but basically having mentorship from a badass clinician would be the bro put it.
Yeah.
Um, and then, yeah, I think more requirements for continuing ed to make sure they're, adhering to evidence, maybe a little bit more uniform. You would hope a little more uniformity. Not that we all need to practice the exact same way, but so that there's less variance, and would be great, in my opinion.
You said it perfectly,
Sexy
man.
sells
Like
though,
I
right? Everyone wants the dry needling, the cupping, the whatever, right? And that's the stuff that sells.
No, I think you said it perfectly, bro. Like I think mentorship is huge, and I definitely want some uniformity within our professions a little bit better. Like, and not just like oh, if I do this, you'll be fixed, kind of like that. So, um, with that being said, though, like man, I think that I don't. Anthony, do you have anything to add on to it?
I think that time would be nice, and like mentorship and or just like admin admin time would be great. And I just mean that in a
Yeah, that's a
general sense.
deep.
Like I think for new grads coming into the profession, like I think exposure to productivity is good, but like um, we should also be developing like our critical thinking and like taking some time to reflect more on our practice, which can be done outside of the job. But like, all right, they call it mentorship, call it admin time, like whatever you want. But like um, adding, I don't know, I guess recognition to that. But like overall, everything kind of just seems to happen the way it needs to. But I suppose I could think about it some more and I could find some stuff.
No, I agree with you guys, man. Like I think you guys are hitting the point. Like we know that we got these things going on within our professions, and if these were changed, I think it would be a little bit more brighter. I do want to say, I think this is mostly for our audiences. How like if you are seeing someone and you're unsure of what's going on, or like a little bit afraid of like asking questions, like just don't be afraid, just ask questions, right? And you can always ask questions about like like how are you keeping up with certain things, certain evidence practice, right? Like what do you do to make sure that you are providing the best uh, uh, practice? And I think these are important questions to ask, and I would highly encourage that our audience to ask questions when they're seeking care. Um, yeah.
Yeah, and if they
Thank
make you
you.
feel horrible about yourself, that's probably a red flag. And if they're so certain in
Yes.
coming to a diagnosis, right? Anyone who speaks in absolutes, red flag, you might want to run while you can. And then also if they make you feel horrendous about yourself and
Yeah.
questioning everything about you, that's also not a good sign.
Yeah.
Have them
100%.
make them feel good and reassure you that those are probably good signs.
Yeah. And I think at this moment that's probably the best thing we could do. Like, because even if you don't totally understand what's going on. But anyway, thank you for listening to our another discussion. I think this was a great discussion. Have a great night.
Good night.